I'm Dr. Reeta Gurung. I work in Tilganga Institute of Ophthalmology for the last 26 years. So it's a very long time to be associated with one institute, and which I did with sometimes with passion, sometimes with dignity, sometimes with frustrations and everything the human can have, the emotions. So Tilganga Institute of Ophthalmology, if I talk about it, it is one of the institutes in which we all can be proud of. I'm not saying that because I'm the CEO and I do everything, but it is a big teamwork. So for the establishment of Tilganga Institute of Ophthalmology, we based on a big survey which was conducted in Nepal, which was in 1980-81. And in that survey, it was revealed, surprisingly enough, was 1 out of 100 people was blind. And that was a big thing in blindness history. And this survey was done by then His Majesty's government and WHO. And we all were involved in that survey. And this survey is quoted in all over the world in eye health sector because it was done very scientifically. So when we got that results of that survey, then the first cause of blindness, we all know maybe, most likely, that cataract was the main cause of blindness. And 72% of the people who were blind was due to cataract. So we had to do something in cataract. The second major cause was because of the corneal problem, like trauma, like infections, vitamin A deficiency. There are so many things. So more than 10% was because of the so because of the blindness of the corneal problem. So these were the two things we had to take care of. If we would be able to take care of those two problems, then 80% of our blindness will go down. But to tackle this big problem, 1 out of 100 Nepali were blind, we had only 7 ophthalmologists working during that time, in 80-81. So human resource development was another challenge we all have in front of us. So we very light-minded people, we gathered together, me, Dr. Rohit, and our board members, we gathered together and we have to do something because 1 out of 100 Nepalis are blind. If we don't do something drastic or something very erratic, then those people will remain blind forever, kind of, and they will die blind. So, so the cataract was the main cause of blindness. What can we do in cataract? First of all, we went and see why people are not coming for treatment in cataract, and the surgery was the only treatment for the cataract. So the first, what we noticed was the lens going inside the eye after the cataract surgery was the main cost barrier. It would cost almost $150 to $200, and that period in 1980-81, very few Nepali could afford this $150 to $200 lens to buy and put in their eyes. That was the most barrier for the patients to come and do the surgery. Second was, there are 2 different types. One, in the cities, you go and ask, you have got cataract and you can't see, why didn't you go to the hospital? And they would say, I don't have money to go to the hospital. How can I go to the hospital and have my surgery done? And if you go to the villages, and you would find we don't have anywhere to go to. Yes, I know I have got cataract, I have got motia bindu, and I know that if I do surgery, I can see again, but I don't have anywhere to go to. I have to go to Kathmandu, walking 7 days, and horses back 2 days, and an old truck for another day. So he or she had to travel for maybe 2 weeks to get to Kathmandu or one of the cities to get his cataract surgery done. So we thought that let's tackle the problem of cataract. So the cost was the barrier, and there was nowhere to go to was the barrier. So those two barriers, what we did was we established Tilganga Institute of Ophthalmology in Kathmandu. And in that Tilganga Institute of Ophthalmology, we, with the help from our friends in Australia and America and all over the world, we established a factory to produce the intraocular lens. That intraocular lens is because the lens, which was given by the God, got very old, and you can't see through that lens. So we had to remove that lens and put another lens back into the eye. So, and that was very costly. So from $150 to $200, we brought down the cost of the lens to $7 in 1994 when we just started our factory. So that was the turning point in cataract surgical history. So that lens made in Tilganga made itself available to each and every person, like be it very rich person or be it very poor people. So they could afford to put the lens inside their eye after the cataract surgery. But when we made the lens, same lens made in America and the same lens made in Nepal would bear very different weight. So we thought that until and unless we make the lens as good as made in America, that lens wouldn't sell. So we hired a very expensive quality auditor from England. It's called SGS, and they audited the quality of our lens. And up to this point, we do that quality audit every year from the same company, from England, and we pass that quality audit, and those lenses can be sold anywhere in the world. So now, from 1994, when we started making our lenses, till now, that time when we just started, only 10% of the people could afford to put the lens inside the eye after the cataract surgery. But now, unless the patient has some contraindication for that lens to go into their eyes, everybody gets a lens in Nepal when they have the cataract surgery done, no matter what. So in intraocular lenses, we are self-sufficient. We do not have to depend on any other country or any other people. So that is one of the good things we did. Secondly, thank you so much. Secondly, as I told you before, that the second major cause was the corneal blindness. Corneal blindness is, how can I put it? Cornea, maybe you all know what cornea is. Cornea is the घडीको sisa. Let's put that way. If the घडीको sisa is कोरिएको and kalo and pohor and everything, the patient cannot see outside and we cannot see inside the eye. So that घडीको sisa, which is we call it ahako nani, which went kaput in many people because of infection, because of trauma, because of vitamin A deficiency. Because of all those reasons, the people, almost more than 10% of the people couldn't see at all. So for that, to combat that problem, we established Nepal Eye Bank in Tilganga Institute of Ophthalmology. And that we worked very closely with Pashupati Area Development Trust and the Lions Club of Pashupatinath. So these people helped us to grow in eye banking. First of all, we sat in the eye bank. We did lots and lots of public awareness programs. We sat in the eye bank and waited for the calls to come in. Somebody died in my house. Can you come for the cornea to take? But that didn't happen because one, people didn't know. Second, people didn't know that the cornea could be donated. Third, because there was no system or no culture of giving the organs. So what we did, okay, enough is enough. No waiting in Tilganga anymore. The eye bank staff has to go and sit in Pashupatinath, in Aregat. So our eye bank technicians, with their suitcase, in that suitcase there would be cornea, oxygen, kit, and everything, went and sat in the ghats and talking with the sadhus and santus and pilgrims and everybody. And whenever the dead body was brought to the ghat, the technicians would go very slowly, scared, and started talking to the families. And sometimes they were scolded, sometimes they were told off, sometimes they were told that you just piss off, that kind of thing. But actually speaking, the perseverance of those people who used to work in the eye bank paid off. So in that year, the first few years, we could collect 2 a year, 4 a year, something like that. But in 1998, when we started going and sitting in Pashupati Areghat, our cornea donation certainly rose up. It went up to 400 corneas a year. And we were really, really excited about it, because it is not the matter of people do not want to donate. It is not the religion, or it is not anything like that. But because people, if somebody dies in my house, in that very moment, I will not be looking for people asking for corneas, because that time is completely different. But if somebody goes there, comes to my family and says, there is a possibility of cornea donation, are you interested? Then I might think negatively, I might think very positively as well. So there were lots and lots of people who thought very positively about it, and then we were very encouraged about it. But as you know, in Areghat, there are so many people, it is out in the open and everything. So we went to Pashupati Area Development Trust, and we always thought that that place is very closed and nobody can talk to them and everything. But we all are human beings, and we said, there is a chance that we can get corneas from Areghat. Can you please give us one room? And the sirs in Pashupati Area Development said they thought about it, they talked about it, and they said, okay, you can have one room. You refurbish the room and use that room as a cornea collection information center. That's what we call that room. And that room was manned by not us. That was manned by the members of the Lions Club of Pashupatinath. So we got help from very small organizations to very big organizations. So you cannot just not count those small ones. You have to take them on board. So that little room, Cornea Collection Information Center, was manned by the members of the Lions Club of Pashupatinath, and they really did help us. And when we started getting the corneas, when we went back again to the Pashupati Area Development Trust Hakimharukoma, then we said, sir, now we started getting corneas. Can you please give us a room so that we can excise the cornea inside the room rather than excising outside the room, which is filthy, which is not very clean, it is not very hygienic. So after a few months, they said, yes, okay, we'll give you a room, so you can use that room. So we refurbished, and we used that room as our cornea excision center. That's how we did. Now, we collect more than 1,000 corneas per year. In 2018, we collected 1,176 corneas. From 2 corneas in 1994, it went that. So there are lots of efforts went in, but if you keep trying, your perseverance will pay off. And that's what we think. So now, in intraocular lens business and in cornea business, Nepal itself can count as a very self-sufficient place to be. So when we did those 2 problems tackled, then we thought that, but we do have corneas, we do have intraocular lenses and everything, but where are the people to use them? We had just 7 ophthalmologists in 1980-81, so we need to produce lots of human resources to use those materials as well as to give services to the people. So we started our residency program, our training program in Tilganga Institute of Ophthalmology. Now we have MD residents studying, we have optometrists studying B optometry, we have M optometry, we have fellowship trainings. So there's a big training institute. It is not a small eye hospital anymore. It is a big training institute which we have established in Tilganga Institute of Ophthalmology. But just having Tilganga in Kathmandu is not enough. That's what we thought. Because to replicate Tilganga in one of the other places would be really, really difficult. It is very labor intensive. It is very financially very intensive. Lots of money is needed. So we thought that, one, we have to we have to continue our outreach programs because people are living out there. And then for that blind person to come to Tilganga and get operated would be a mammoth task for that family. Expenses-wise, time-wise, loss of wages-wise, everything-wise. So we thought that we have to continue doing we call it eye camps in those villages, so we continue doing that. And at the same time, maybe it is better to establish smaller hospitals dotted around the country. So in our system, we started our hospital in Hetauda, where 3 ophthalmologists are working, who does about 4,000 to 6,000 cataract surgeries and other subspecialty services. And another one is coming in Nijgarh as well. So this is the system we are trying to establish. Like for the very grassroots level, we'll have those eye camps, which is very periodic. And for others, in the district headquarters, we have community eye centers, where it is a permanent establishment where no ophthalmologist is there because we don't have that many ophthalmologists as yet. So there is ophthalmic assistant, which is the staff nurse equivalent in eye care. And we have community eye hospitals like Hetauda, where 2 or 3 ophthalmologists are working. And at the end, we would have a bigger hospital like Tilganga. And our dream is maybe the hospital like Tilganga should be in all the provinces of the country, like in 7 provinces, whereas those Hetauda model should be replicated in all the districts, in 77 districts of the country. Community eye centers in all the VDCs, whatever you call it now, and all this, even now, those eye camps has to be done in very remote areas because if we go to Nepal's geography, then up on the mountains, about 7% of the land is occupied by 7% of the people live on the mountains, and they are very scarce. The density of the population is very small, so to keep one big hospital up on the mountains would be really, really resource intensive, so we cannot maybe afford to do it now. So for those people, we have to have those eye camps kind of service delivery system. But if we come down from the mountains, there will be big hills. The hills are not rolling hills like in other countries. Our hills are really, really massive hills. And on those hills, about 68% of our land is occupied by those big hills, and where about 40% of our population live in those hills. And for those people, we need community eye centers in each district where there will be continuous outpatient services, but the surgical services has to be kind of periodic. But as we come down to the community eye hospitals where the surgical as well as the outpatient services will be regular, but the subspecialty services will not be there. There will be basic cataract services and some subspecialty services will be there in those community eye hospitals, and bigger hospitals like Tilganga. If our dreams come true, then it will be in all the provinces, and then people do not have to travel to Kathmandu from Mechi to Mahakali to get the services. That is maybe one of our dreams, but to replicate Tilganga, as you know, it is very difficult even in those provinces. So we try to make community eye hospitals like we have in Hetauda in all the districts, and we are talking with many organizations to come and help us to realize our dreams. At the same time, people can get the eye services closer to their homes. And doing all those things, we in 2012, a small group of ophthalmologists, we gathered together and tried to see how those camps is helping the people who cannot otherwise travel to Kathmandu or to the centers where there are bigger eye hospitals. Then we found that most of the people coming to Tilganga or bigger hospital would be men who could travel independently, who has got power over the wealth of their household. But the women with children, they were left behind. They were the ones who could not come to the bigger hospitals to get the services. So we have to take our services closer to them so that they can have the services and they can be not blind anymore. So those smaller hospital concept also came from there. If we take our services closer to the people, then the women and the children and who are not able to travel to bigger cities can have the services, so the equity of the eye care would be addressed. And what I want to say that combating the blindness is not somebody else's or one person's job. Yes, Dr. Reeta is there, the big team is there, so it has to be a teamwork. But to follow that vision and to implement, we all have to be together. But it is a teamwork, but at the same time, the individual person's commitment comes to there to realize that dream. The individual commitment I would take, I do my dharma, I do my karma. If I do that and somebody else, my colleague also does that, then everything falls into place. If I say that that person is blind and my duty is my dharma is to treat that patient, and if that blind person's family's dharma is to take care of that patient after I do the surgery, then everything comes together. So if everybody follows their dharma and karma, I'm not saying religion per se, dharma doesn't mean religion per se, but dharma to treat that patient is my dharma with my head, with my heart, but after I treat that patient, if that family doesn't take care of that patient's post-operative period, then even my dharma doesn't work. So the dharma and karma has to become from both the sides, then everything falls into place. Now, this all based on the evidence, the first National Blindness Survey, and we worked according to that findings of their survey. And recently we had, in 2010 also, we had a blindness survey. And in that survey, I'm very happy to tell you that the blindness rate, the prevalence of blindness has dropped from 0.84% to 0.3%. I mean, it is not because just I did something, but it was a teamwork, but at the same time, commitment from individuals. So individuals do play a big role in the team, but if I do not fit into that team, maybe things don't work as well. So I still think that, yes, teamwork is the best. Without team, we cannot achieve anything. But at the same time, the members of the team has to have their own dharma and own karma, which leads us to progress and prosperity. Thank you so much.